My name is Peter Lillyhoy. I'm an associate professor here at Rice University. I'm in mechanical engineering department and also in biomedical engineering. So in this next session, we have three speakers, and it's going to follow a similar format as a previous session. So each panelist will have about 12 minutes to share, and then we'll follow up with a time of Q&A. So as I introduce each speaker, I would like to ask them to come to the front and sit down, and I will introduce all the speakers first, and then we can continue with the presentations after everyone has been seated in the front. So the first speaker is Dr. Fatima Bello. She is an assistant professor of internal medicine at UT Health at Rio Grande Valley School of Medicine, and she will be discussing on the clinical perspectives in the Rio Grande Valley communities. Our second speaker is Casey Howard. She is the Associate Director of Technology Development and External Relations at Rice University, and she will be discussing on needs findings in the Rio Grande Valley region as well. And then lastly, our third speaker is Dr. Matthew Wettergreen. He is a teaching professor in the Department of Bioengineering at Rice, and he's also the director of the Global Medical Innovation, or GMI, program at Rice. And he will be discussing about the GMI program and the project related to the Rio Grande Valley community. So I just want to give a brief kind of background. So if you're not familiar, the Rio Grande Valley is a part of Texas in the southern kind of tip of Texas. It borders the Rio Grande, which is a large river on the border of the US and Mexico, and it has some of the highest rates of poverty and impoverished communities in the United States. So I think this session is going to be very kind of informative and provide a lot of kind of information that can be relatable to many other parts of the United States and other parts of the world that have similar conditions. So without further ado, I will allow Fatima to begin her presentation. Thank you.
My name is Fatima Bello, and I'm an assistant professor of medicine at University of Texas, Rio Grande Valley. I also wear different hats with the UTRGV Knapp Medical Center internal medicine program. I serve as the program director as well. So today I'm going to be sharing my experiences and my perspective practicing medicine in the Rio Grande Valley for the past 8 years. Okay. So the Rio Grande Valley, like Peter said, is located in the southernmost tip of Texas, very, very close to Mexico. Fun fact, we're actually closer to Mexico than any other major region in the United States, and that's very important because there are a lot of binational influences both ways. A lot of culture, similar culture from Mexico and the United States, a lot of immigration as well, and a lot of like health issues across the borders. There's a population of 1.4 million approximately, and we do have 4 counties: Starr County, Hidalgo County, Cameron County, and Willacy County as well. In terms of ethnicity, about 93% of individuals in the Rio Grande Valley identify as Hispanic or Latino. And that's very important because if you compare that to Texas and the United States, in Texas about only 41%, whereas in the whole of the United States, it's about 19%. So that's a huge, huge difference when you compare the region versus what we have in other regions. So this is a word cloud that I did. A few years back, I attended a similar conference like this, and I told them, when you hear the Rio Grande Valley, what comes to your mind? Can you just, type something? And this is what it came up with. So it's interesting what these individuals that had never been to the valley came up with. And this is very important. I'm going to be referring to it again later, but just, so I would have played the same, but I only have 12 minutes, so I won't be able to do it today. But just keep in mind whatever comes to your mind when you hear the Rio Grande Valley as well. So I'm going to be talking a little bit more. We have a lot of social issues, like you can imagine, but I'm only going to be focusing on diabetes because we are the diabetes belt of the United States, and we do have a lot of diabetes. And I also chose diabetes because diabetes is it has a lot of social context to it as well. There's the obesity, there's the lifestyle, the other social context, transportation, and everything. So I think it's a very good example. When you compare the rates of people with adults with prediabetes in the Rio Grande Valley, it's 11.3%, and compare that to what we have in Texas, about 7.5%. Similarly, in the Medicare population, about 43.1% have diabetes, whereas it's 28.8% in Texas and 27% in the US. Almost double the numbers for everything. Age-adjusted death rate to diabetes as well, 33.3 in Rio Grande Valley versus 23.8 in Texas and 22.6. And with diabetes come a lot of things, sedentary lifestyle, obesity, and not surprisingly, we do have a much higher rate of adults who are sedentary, 39.9% compared to 23.7%. So I'm not going to waste a lot of time on this slide, but diabetes again is it's a multi-systemic disease. It does affect basically every organ in the body, and that's why it's very important. So from the head to the eyes, to the kidneys, to the bones, to the heart, and more importantly for this presentation, the foot. So diabetes does affect the foot, and not surprisingly, we do have a lot of amputations in the valley as well. We have one of the highest rates of diabetic amputations in the United States. So I'm sure we've all seen this video on TikTok or Instagram where people are walking on like fire or like on glass and they don't feel it. So many of them actually have diabetes, and that's what happens. That's how they sustain some of these injuries, that maybe if they step on stone, it gets infected, the wound doesn't heal, and then leads to amputation down the line. The picture at the bottom of this slide is one of our patients. The students facing him are Rice University students that were here, that were at NAP last year. So I have his permission to share this photo, and I also have a video coming up as well that I'm going to be playing, but I do have his permission. He's had diabetes for 5 years, and he had an amputation 3 years ago. And interestingly, he's been coming to the clinic every week to nurse that wound, and he still has the wound till today, over 3 years, just to kind of give you how this affects everybody. So when I think of what happens in the valley, two things that I feel like if we're able to solve, I feel like we've solved at least half of the issues. The first is poverty. There's a lot of poverty in the Rio Grande Valley. About 23.3% of families live below poverty level in the Rio Grande Valley, compared with 8.7 in US. That's almost times 3, and 10.5 in Texas. Similarly, education as well. In the Rio Grande Valley, about 17.63% have less than a 9th grade education, compared with 7.32 in Texas. To put this in context and why these two are very important, if you had to choose between your next meal, for example, lunch or dinner, versus going to see a physician that is going to screen you for something that you can develop in 50 years down the line, you're going to choose your next meal. And also education, education plays an important role. It gives you an opportunity to, make healthy decisions for your health, for, just generally life choices. So these two are very important. And even poverty, basically, there are so many studies that are showing that poverty, just being poor on its own, it's even a very, very big risk factor for cardiovascular health, because it's a chronic stressor, causes like inflammation. So if we're able to solve like poverty and educational, low level of educational attainment in the valley, I always feel like we've solved half of the problems in the valley. This other slide as well, so the Rio Grande Valley also has, oh, I don't know what I pressed, okay. The Rio Grande Valley also has a very, very high unmet demand of physicians, family medicine, psychiatry and pediatrics. The Rio Grande Valley is projected to have the greatest percentage of demand unmet by 2032 everywhere in Texas, and that's very significant. For a region that is already struggling already, now putting this on top of everything even makes it worse. So I'm going to be sharing Mr. Luna's experience shortly, and I'm going to...
Well, my name's Geraldo Luna. I'm 55 years old. Born and raised here in the Valley, but I've been up north and we used to be migrant workers, so we go up there and come back. And like I said before, it's something that us here in our culture that we have a commute that we work and go up north, come back.
Okay.
But me personally, didn't know that I had it, but I found out like 5 years, and basically 5 years.
Okay.
And I have 3 years for this move. So
Okay.
I'm trying to every day, go every day.
Yeah. Yeah.
Yes, I would always wear, I should, always been, because I'm always barefooted. And knowing I'm diabetic, because I wouldn't be barefooted, I would wear shoes. So probably this wouldn't happen.
Correct. Correct.
Well, the one thing is that being Mexican, I mean, I want to enjoy all the foods that are out there, but we can't out of moderation.
Correct.
But it's hard. It's hard, and with this amputation, it's kind of hard also to. I mean, good thing I have this to move around, but
Correct.
I wish I could
Walk.
do it walk
I
and
know.
stuff. But it's every day's a challenge. I know there's a lot of, like you said, engineers. There's a lot of mechanical, something different. I've seen it on Discovery channels and stuff like that, where people with amputations, they can do, their life will be easier for them. Like whatever they like, there's an arm and there's a leg. Coming from a diabetic family, not knowing, I have another brother that's also amputated. And like I said, we don't stop. It's what we eat. It's the culture, the food. But in the way it affected us, it's just that it's hard for us to eat right. Because something that we ate whatever.
Correct.
Tortillas and all the good stuff
Right.
that South Texas has to offer. And I'm pretty sure each culture has something like that.
Okay, so that's Mr. Luna, and you can tell that he really loves South Texas. He loves the culture of South Texas. And I even count him, I feel like he's one of the lucky patients that I know because he has the wheelchair, he's able to communicate in English language. A lot of our patients actually do not speak English, they only speak Spanish, which also puts a certain limitation. You know, they do not have transportation. He has the wheelchair, and he has insurance, which is very important in our population. So that's not an isolated thing. That's actually very, very common in the valley. And yeah. So you remember this word cloud that I showed earlier from the adults that, you know, at a conference I told them to tell me what comes to their mind. So last year I was invited to my daughter's school, you know, for a career talk, and I asked them the same thing. What comes to your mind when you think about the Rio Grande Valley? And this is what they came up with. So I'm going to let you take a moment and let this sink in and compare what these kids came up with and what I've told you about the valley, what Mr. Luna has told you about the valley, what the statistics show about the valley. You can see that this is a big difference, right? The kids see a future, they just see like a community. They see a life with their, you know, their family on the ranch, with Raspal, with their dog, you know, with their going from church. But what we currently have is a stark difference if we keep going this way. These children also deserve joy. You know, they are not even asking for big miracles. They are just asking for, you know, if I'm sick, I want to have a physician to see me. They just want the basic things. And honestly, they deserve this. If you ask me, they deserve a future. They deserve to also have the right to live just like any child that is born anywhere else in the United States. Because if things continue this way, many of the children currently in the valley, their life expectancy is going to be very different from children that are born elsewhere. And this is a call to action to everybody in this room today, whether as engineers, biomedical students, bioengineers, or future physicians, hospital leaders as well. You know, whatever we can assist with the Valley. The Valley is a very incredible, very lovely place, beautiful people, very nice people. And we do have public health access that which I've not seen anywhere else in the United States where I've lived. We just need that little prop. And, you know, here we're talking about innovation today. At the heart of innovation is hope. And I'm hoping everybody in their own little way, whether it's from developing something from Mr. Luna or developing something from one of the kids in the Valley, in whatever ways we can contribute, so we'll be happy to have it in the Valley. Thank you so much.
So really quick, I know we keep putting this group think tank in front of you, but Noel and I have a little bet, and I mean, I said everybody in here is able to submit something before lunchtime, and he said absolutely not. So if you guys could make me win, that would be great. I'll give you a few minutes after my talk before Dr. Wettergreen's to actually talk to your neighbor and then submit something. So all ideas, we're brainstorming, no bad ideas. Okay. So I'm going to talk to you a little bit about clinical needs finding. And as an educator, I firmly believe that biomedical engineers belong in the clinical environment. And so I teach a number of different needs finding experiences in different parts of the world. And we've been going down to the Valley with Dr. Bello for this is the 3rd year. And I think the reason why biomedical engineers belong in the clinical environment is threefold. There's other reasons as well, but most importantly, biomedical engineers need to understand the environment that the devices they will one day design will be used, right? Because we don't understand what clinical medicine looks like until we go and stand there and watch a surgery, watch a clinic. And then they need to understand how to identify gaps and find unmet clinical needs through observation and interview. And then lastly, they really need to learn how to engage with clinical faculty and staff and be able to talk kind of both languages. We can't just go in as an engineer and talk in engineer speak and have a doctor talking doctor speak and understand each other, right? So we need to be able to talk across disciplines to really solve these problems. The framework that we use when we do needs finding is around Stanford's biodesign process. They have a wonderful book, they have lots of online resources, but this illustrates the process, and so usually this happens over the course of a whole year if you're in a biodesign fellowship, and it starts from understanding your strategic focus and finding needs and ending with a commercially viable solution. But within the courses that I teach, we really only focus on needs finding and sometimes needs screening. So that's going and observing and trying to understand what are the real problems that are happening. So I think some of the previous speakers today were saying, yeah, we really need to listen, and we need to listen and hear what people are actually saying and think about what problems we're solving, and that's the real goal here. So the skills of needs finding, I think, could break down into translation, investigation, and prioritization. So as a student, you need to be able to see and hear things and translate that into what is the unmet need here, where is there a real problem that I could help solve? And then investigating, kind of cross-referencing sources and ensuring that what you're seeing is not just a unique situation, but it's a valid, need that's you could solve for more than one unique case. And then lastly, prioritization. So I don't know how, but I always ended up in these roles where I'm thinking about the problems, and I feel like I could just learn about problems for the rest of my life, but at some point we got to pick which ones are we going to prioritize, and so a systematic way to prioritize which ones are going to lead to the biggest impact, that's another part of what the students learn. And I think at the end of the day, needs finding ensures that technology engineers work so hard to develop is addressing a genuine need. So, I get to go down to the Rio Grande Valley, and it's almost my favorite time of the year. I love it every time. It's like going home. So, and as someone from Montana, that's really strange to say. But anyway, so I'm going to show you a little video that kind of captures better than anything I can tell you what this experience is like and kind of how we do this with our students. Sorry, stand by. You're going to see the video in a second. As part of this experience, the students are doing basically systems mapping to understand the upstream and downstream aspects of kind of what the problems are. They're doing interviews with clinical residents, patients, public health care workers, various nonprofit organizations, and then they'd spend some time with Dr. Bello and her team doing clinical observation. And one thing, the first year I went down, we went and spent time at Knapp Medical Center, and I really focused only on making sure the students understand diabetic foot disease and the clinical treatment landscape. And I left, and I was like sitting on the plane, I was like, I totally missed the boat there. Like, I totally missed the real problems. There's all these upstream problems, social determinants of health, that the students need to understand, because if we don't talk about those, like, this conversation doesn't make much sense. So we basically reformulated it to be able to really talk on the first day about kind of the upstream challenges, and the second day, more of that clinical treatment landscape. And they get to deeply engage with stakeholders, and so they have a lunch between the medical residents and our students. You see Cannon, who talked to us yesterday, he's there talking with one of the residents to really understand and do that conversation that I talked about, right? The doctors, the young doctors who are seeing these problems, who are learning, they need to be able to talk to these engineers and explain what they're seeing so we can both be part of the solution. Okay, here's the video I told you about.
There are a lot of social issues here as well that you probably would not see elsewhere. We have people that cross the border, we have people without insurance, we have people that have never seen a physician in 50, 60 something years. So a lot of other social issues, but we do our best, we do what we can. With the help of you guys, we're hoping for a much brighter future than what we have today.
Rice bioengineering students are here in the Rio Grande Valley, immersing themselves in the community.
We are going to talk about how food insecurity is impacting the Rio Grande Valley. We're going to talk about what does healthy eating really mean.
When they go back to Rice, they're going to bring with them the local needs they discovered.
What we'll see here at Subclinica is you'll see a representation of really the community that we have here in the valley, in this immediate region.
And work to develop healthcare innovations to support thriving urban communities.
We're the lead in terms of diabetes in the state of Texas, top in the country. We're the top for obesity in the state of Texas, and we're one of the top in the country as well. And we're also, unfortunately, we're one of the tops in terms of highest amputation rates. We need you, wonderful brains like yourselves, to come alongside, I think, the physicians and see how you all can maybe help with some of the struggles that we see.
You guys have to get closer. This has been seriously a life-changing experience for me. Getting to view the patient perspective and gain that insight just kind of sheds a whole new light on these diseases and these conditions and the challenges that revolve around these conditions that we may or may not see every day.
And then did you have any recurring ulcers before amputation?
Actually, they cut my toes off first, and I didn't have no wound care.
We have some pretty strong partners who are able to deliver strong experiences to let them see many different stakeholders and to see a health challenge that maybe a medical device is what's needed, maybe it's also like a social program. There's so many complex factors, and so I think it's a really good exercise in thinking about complex problems and what is the role of the engineer and how do all these things interrelate.
What happens here on the ground is there's a really beautiful community of people who are very dedicated to quality of life of everyone who lives here. There are issues of access to care, but there are also many socioeconomic determinants of health that can be addressed at the local level with what we have and the resources that we have.
And so that's what we try to do here at Brownsville Wellness Coalition, is just turn a tragedy into something better, grow food, and just make this community a lot better.
This is the reason why I'm doing the research, why I'm doing, to serve communities that need it the most. And having all that knowledge kind of helps contextualize some of the research I'm doing and kind of keeping that goal in mind when I want to, for example, develop a new type of technology or a sort of drug delivery system.
There's a difference between making something that works and making something that can actually serve others, and I want to make sure I can make something that's impactful.
This partnership that UT Health Houston has with Rice has been really fun and engaging, and it's always great to be able to kind of show off the valley and see how it's a jewel of South Texas, because people get so wrapped up in the rhetoric of what they hear about the Valley, and then you experience it and you're like, wow, this place is incredible.
Okay. Yeah, so I'm going to switch gears slightly. So when we come out of this experience, we ask the students to think about needs, kind of the same exercise that we're having you guys do when you think about submitting a need statement or an opportunity statement. And so we have them do this map and understand upstream and downstream features and look for the crux nodes where they think impact could really happen if they adjusted them. And one of the areas that we always come back to is really diabetic foot. Because if you look, the 5-year mortality, if you have a lower limb amputation, is 52 to 80%. These outcomes are worse than cancer, right? So we need to be able to stop that progression. And so our students submit different need statements, right? And we think along the flow of care, like, are we trying to screen for early foot ulcer? Are we trying to screen for diabetes? Are we trying to provide, load-bearing support, or assess nerve damage, or prevent re-injury? And so part of this prioritization process is really understanding with our clinical partners, where are those points where we're gonna move the needle the most? And so we worked together, the three of us and the rest of the partners at the RGV, and we decided to move forward with a project that Dr. Wettergreen's gonna talk about. And the initial need statement that this is a long road, but we decided we really wanna start working towards some sort of technology that our students are developing to help the community. And this is where we started. So a pressing need for accessible community-based technology that can identify early signs of diabetic foot complications for individuals in the RGV to enable timely intervention, right? So if we can intervene early, then we don't end up on that negative feedback cycle of amputation that doesn't heal. So this is a quick call to action, and then I'm gonna have us do a 2-minute activity. But if you're a clinician in the audience or a researcher, and you have basically a need area that you're interested in, myself or my students, we're happy to explore ways to collaborate with you, go understand the problem, understand kind of a similar exercise, like how can we help? How can we change the narrative there?
Today, I'm excited to tell you about a 1-year Master of Bioengineering program called Global Medical Innovation. It's one of 2 professional master's programs that Rice Bioengineering has. And it's going to cap off this story you heard with Dr. Bello introducing you to the Rio Grande Valley and some of the challenges that we face there, and the story of Casey Howard sharing how our students go. And up until that point, they've learned that more technology and more healthcare is almost always the solution. And instead, what they find is that you've got to go upstream in order to solve some issues, and you've got to take into consideration the patient and the social determinants of healthcare. In the GMI program, which I'm going to survey for you here, you're going to learn about how we spend a year preparing students for professional practice in the medical device industry. The GMI program is equal parts engineering, business, and medicine. It's also what we think of as the future of design programs, a holistic, year-long experience where students are put through project-based work, simulating professional practice, and preparing them through technical work and professional work. Students actually start this program in June with what's called the International Summer Experience. They participate in a clinical observation boot camp, a medical innovation boot camp, and then they spend the summer working for a medical device company or doing clinical observations in a hospital. I failed to mention this International Summer Experience is in Costa Rica or Brazil or Kenya or next year Ireland, where our students learn a global perspective on healthcare different than their country of origin. Shown here are some of the companies or hospitals where our students have worked. In the fall and the spring, our students work on 2 project-based classes. One that is engineering focused, where they start with an unmet clinical need and advance to a proof of concept prototype. And a second, there's a business class where they start with an unmet clinical need and they advance to a pitch made to potential investors. In the first semester, in both projects, they form teams, they do clinical observations, they do the primary steps of the biodesign process and the primary steps of the engineering design process. They go to career fairs to look for full-time positions in in their area. And that's because pragmatically, this program is focused on helping students to secure full-time jobs. This is also when we get next month to go to the RGV. And what I'm going to talk about as one of these projects is the RGV project that we're working on currently. In the spring, students in the GMI program refine their prototype. They do verification and validation. They set up clinical research plans and they refine their pitch, and they participate in design competitions around the United States. In the engineering project, students are pitched on projects from our local, regional, or global partners. They go through the steps of the biodesign process and the engineering design process and learn the FDA waterfall while they're working for 1 year at the Oshman Engineering Design Kitchen, our makerspace that is a global leader in active learning, project-based learning, and engineering design. In the second project, students do a business-focused project following the biodesign process, start to finish. And the topics in this include how to take a clinical observation and turn it into a project. They then form teams. They do market and competitive analysis. Rice is appropriate for this type of atmosphere because Rice Business is the #1 graduate entrepreneurship program in the nation and has been for 6 years. I'm now going to focus on one current GMI team called Soul Search, made up of Alex, Victoria, Ray, and Luisani. They're working on a project with Dr. Bello and her collaborators in the Rio Grande Valley. And the slides that I'm going to show you are from their first design review. In industry, a design review is a structured conversation with technical experts, technical manager, where you walk through some of the decisions that you made. And we do design reviews each semester as a way to help students learn what it's like in professional practice. What you're about to see is like the director's commentary on the DVD, where I'll show some slides from the students and talk about what aspects of their journey in 1 year they have gone through. So the partners for this project, including Dr. Bello, as well as Dr. Cantazaro, Dr. Tijani, and Dr. LaFontaine, were started with the preliminary need statement where they wanted to be able to detect foot ulcers and report in a community space for community members some risk factors. And they wanted this to be a device that could live in a grocery store or a hardware store with no cost to the user. In the GMI program, we use what's called the Web of Mentors. This is based on the Zone of Proximal Development, which helps students and individuals scaffold their learning beyond their normal capabilities by using mentors in a variety of areas. For example, in regulatory, or for example, in public health or clinical support. The students then go through the initial steps of the engineering design process, researching the problem, not the solution. They explore the anatomy, the pathophysiology, as well as the clinical presentation. Some of them go into clinics or do interviews with stakeholders, which I'll talk about next. These students went and looked at analogous solutions at Fleet Feet, public blood pressure cuff, and also an orthotics device by Dr. Scholes, with inspiration for how their device could exist and live in a public space. Patient testimonials and interviews that they conducted are part of the Stanford Biodesign process, another of the models that our students go through. They interview stakeholders, they report on this stakeholder interview process, and this simulates the research step and the patient testimonial step of the biodesign process. They also develop design inputs, and they place this into a design traceability matrix. We use JAMA Connect, which is one of a number of EQMS packages that we feel our students must learn so that they can be conversant in ISO standards and also understand how to tie design inputs ultimately to verification and validation, which is not only important in industry, but is important for our students to talk to industry when they're in an interview process. And this is based on the FDA waterfall diagram and process. At the conclusion of the design review, the students present a refined and a validated need statement. And for the participants of the design review, we want the students to hear this. You are following the right need statement, and you have validated this need statement, and we support you to continue on. And so this team's refined, validated need statement is that there's a need for a free-to-use, community-centered method to identify diabetic foot ulcer risk factors to minimize the rate of foot amputations in underserved communities. And the students did this about 2 weeks ago. Now, as they go through the rest of this semester, they will work towards regulatory and IP as they seek solutions and developing solutions. And then in the spring, they will refine their prototype as well as conduct verification and validation tests. What we've just told is a 3-person story about unmet clinical needs that are then refined and down selected and placed into an innovation-based process is something that we do with multiple different projects and different unmet clinical needs. And I want to advocate for this type of partnership at your own schools and at your own institutions as ways to solve these problems in the long term. And what our problem that we're looking to solve will do in the long term is launch a multi-year project where this year we will collect data about community members' feet. And in subsequent years, we hope to build a machine learning model that can predict particular risk factors based on the analysis of this image set that we've developed. So we're hoping that this can be a multi-year partnership with UT RGV. There are a number of collaborators for this project, including funding from the Center for Clinical and Translational Sciences, SciTech, and also some of our partners shown here, including Dr. Bello at UT RGV and some of her collaborators. Thanks for allowing the 3 of us to talk about this exciting project and this program.
This is for all of the panelists and speakers. So each of you have very diverse kind of backgrounds and had opportunities to travel to different countries. So how would you compare your experiences in the Rio Grande Valley to some other parts of the world that you've also traveled to with similar challenges?
I can start. So I'm originally from Nigeria. I grew up in Nigeria and I went to medical school in Nigeria, actually. So some of the things that I see in the Rio Grande Valley, I wouldn't say there are things that I see in Nigeria, but I feel like within the United States, the things I see in the Rio Grande Valley, I haven't seen them like when I lived in Boston and even in Alabama. So for sure, I mean, I don't want to compare orange to apples, but definitely there's a difference in what I've seen in the Valley versus what I've seen elsewhere.
Yeah, I don't know if I can make a direct comparison. I think it's, you do see, you know, I was in Kenya and I had some students observing and they were talking about this idea of people not knowing they had diabetes. And this, like, there's not a huge emphasis on these lifestyle diseases. And so I think, you know, these underlying things that are happening and being able to diagnose and be aware of diabetes, that was probably a common thread that I saw just in the last year.
Rather than share the places that I've been, I think what I want you to understand about the GMI program is that we're trying to show students multiple lenses of how healthcare happens. And we want them to see the Houston lens, which would be local and US national, but also global if they do the summer program. And then a third lens, which we call in country, out of context. And that's the RGV, which is still in the United States and still in Texas, but breaks their assumptions about what they might want to see and how they might actually solve problems.
Hi, my question is for Dr. Watergreen. So what happens after the year ends? What happens to the projects that the students worked on? And is there something in place maybe to allow the students to continue even after they graduate and get the innovation into the implementation stage?
That's a great question and a really hard one that many design programs around the nation grapple with. The projects all have project partners, and it is our hope at the end of the year that the project will continue to be worked on by that project partner or through a partnership with the students as well as the organization itself. In some cases, our students go on to start companies for these projects, but it is a long road in order to develop these technologies, and that's why it's critical that there are partnerships in place that will allow this to continue to live. Many of our students get jobs, and we're very happy when they get jobs, but we also have to find partnerships for these projects. Thank you.
So my question is, after listening to Lisa Hirschhorn talk about implementation research this morning, I'm wondering if there's an opportunity in collaborations like the three of you have to think about accelerating the path to impact by bringing in implementation science as part of the design journey.
I thought the same thing as she was talking. I was going to go track her down. Yeah, I think in a different context, in SciTech, where we're looking at cancer and point of care diagnostics, we are looking more closely at, there is some overlap like between implementation science and needs finding, and how can you, if you initiate that implementation science framework, you give a little more structure to the process and identifying those triggers. So completely agree.
I think yesterday and today we've heard a lot about the social determinants, non-medical drivers of health, and kind of the complexity that arises when you think about the whole person and their context. So I wonder what happens when in the needs finding process, either students gravitate towards or the end user gravitates towards some of those non-clinical needs, and what happens to that type of a problem. Is there like a social service delivery engineering process that you've ever explored, or do you bring in like systems or industrial process engineers into the conversation when it's not like a biomedical problem, or do they vote out the non-biomedical problems?
I asked them to highlight like 2 crux nodes, and then they have to highlight 2 crux nodes that can be impacted by engineering, and we kind of focus on those, knowing that those other ones could be more meaningful. But I think I'll turn it over to Matthew. I think he could say maybe something about Design for America.
Yeah, you raise a really valuable point in that there are many potential types of solutions, and some organizations are better for those solutions. Design for America is a national organization that uses human-centered design and often develops solutions that are services, and that is one successful example of how you could take an unmet clinical need and then solve it with a service. And that, again, is a national organization that can do that. In design programs, it's challenging to develop a service, and each design program has its own specialty, whether it can develop an app or code or an algorithm or a physical device.
That a bit, if you could help us understand, once somebody has had that amputation, or you featured that one patient, he was there and he's coming weekly and it's not healing, is there something from, as we as engineers, as innovators can think about, right? It's one thing, we've talked a lot about diagnosing people and helping them recognize it, but something from a clinical care perspective, that why these wounds persist or why these individuals are at such high risk for mortality, that's beyond like their lifestyle choices and environment.
Thank you. So the main challenge, and that's a good question as well, it's something we struggle with all the time, especially like you can imagine in the Rio Grande Valley. The greatest challenge is once you have one amputation, like imagine if you're already like functioning at like 80% because you're unable to walk. But the challenge is the main things that put you in the place for amputation in the first place, many times they get worse when you have an amputation. So for example, let's say in the first place you didn't have insurance, so you didn't go to like your primary care physician to get your feet checked. All of those things are still there, and now you have like something added on top of it. So that kind of increases your risk for another amputation, if that makes sense. So that vicious cycle just continues. Now you can't move around, now you don't have transportation, you still do not have insurance, you still cannot see a primary care physician. So basically everything else is still there for you, and unfortunately it gets worse. How we can mitigate that, unfortunately, a lot of social service, a lot of social determinants of health issues that it's impossible for one person to fix. I think these are things that have to be addressed like on a systematic issue, like, we need a lot of help, let me put it like that, and it's not just something that I don't even think the local government can do it. It has to be like a federal government intervention or something like that. But once you have something, it's just like when you're already on a low side of your life, then something happens and puts you down. That's kind of how I can explain it. So it's not easy to fix just like that. It's just what it is sometimes, unfortunately. Did I answer your question?
Hi, great presentation. I'm really interested about the unique case of the Rio Grande Valley, how you mentioned it's like influenced by Mexico and the U.S. Like, I feel like for what you're doing with rice and bioengineering, as well as partnering with that region specifically is just a unique environment to work within, exploring needs and everything like that. My question is to tying in how you're bringing in partners from healthcare, from engineering. Have you also explored people in the local government in that kind of bridging that gap between the U.S. and Mexico and things like that, or is that a broader issue, like you mentioned, federal government? Or, but I wonder if bringing in local legislators and politicians onto those teams might add a little nuance to the conversation as well.
So I can't speak to the politics side, unfortunately, but I know there's been a lot of collaborations on the two countries, from the US side and also from the Mexico side as well. It's been a lot of back and forth, that I can tell you, and there hasn't been a lot of success recently, but I know it's a continuous conversation, and they are trying to, we've just standardized one thing at a time, even if it's just but so many things actually going on. I can't really speak to that, unfortunately, but.
And then as far as local policy, so we also work with UT Health Houston in Brownsville. And so it's a school of public health. So they have lots of really interesting initiatives that they're doing. And for instance, I might get this wrong, but I think they lobbied to get more recess time. The kids weren't having any recess. So I would say that channel is probably the closest to engaging on the policy side locally. And I think they have had some good wins.